Hello and welcome to today's episode of Future of Care. I'm your host, Dr. Arnab Paul from Homecare Association of India. Today, I have a very inspiring guest. She's a cancer survivor, and she eventually founded a great organization called CanSupport. She's a founder president, and she basically organization provides palliative care at home. That's her forte of the main core competence of that organization. And thank you, Harmala, for taking the time out, and thank you for being here. Most welcome.
It's a pleasure. Thank you for having me.
So, uh, before we begin, let me throw some stats out. There was like 15.7 new cancer cases detected last year in India, and one in nine Indians are supposed to develop. I mean, there's a probability they are going to develop cancer, some form of cancer, and that's huge. I mean, and moreover, there are 5 to 10 million patients who require palliative care at home, and probably only 4% or more, less than 4% actually end up receiving it. And we are going to talk to someone who's a torchbearer of providing palliative care at home. Um, so before we begin, Hamala, you were working on your PhD, right? When you were
Correct.
when you were diagnosed with cancer. Can you take me back to that moment? What you felt?
Well, I never expected it to be cancer, frankly. I was working on my PhD, as you say. So I was eating a bit erratically and losing weight.
Mhm.
But no red flags really went up for me. I walked into a clinic. I was in McGill University in Montreal, Canada. Walked into a clinic and said, I'm not feeling too well. And I had a cough, a fairly persistent cough. And they said, no, no, no. They poo-pooed it and said, maybe you need to just take some time off. You're working too hard, and so and so. And it was when I developed a pain in my back, and the cough was persisting, of course, and I had night sweats, that I became a little anxious and spoke to a friend of mine who was a nurse, who suggested that I should meet the doctor she worked for, who was a neurologist. Anyway, he examined me and said, neurologically, you're fine, but I'm just worried by the pallor of your skin. And I'd like you to have a blood test done. And one thing led to another. And finally, I was diagnosed with Hodgkin's lymphoma, which is a type of lymphoma, which fortunately is quite treatable. So I was lucky in that way. I was also young. I was about 33. Of course, I had a 3-year-old son, and my husband was with me at that time. He was an academic. So it was a difficult time. And frankly, I just couldn't believe it. I thought they'd made a mistake, but one tends to do that when you receive difficult news, especially, I would say, because I realized how ignorant I was about cancer. And that the only thing I knew about cancer was that it kills. That's all. And that's what was responsible for the reaction of fear and shock and the denial. And that's when I realized that I needed to educate myself about this illness and disease. And a whole new world opened up for me after that.
Right. I'm just wondering what felt unacceptable to you, considering the treatment that was happening around that time in India. What made you? What was it calling for cancer support?
Well, after I finished my treatment in Canada, in Toronto, we came back as a family. And I had seen, while I was at the Princess Margaret Hospital where I was treated, these wonderful volunteers who were cancer survivors themselves or people touched by cancer in some way. And they would come into the hospital and they would serve us tea. They would sit with you. They would talk to you. They ran a little shop in the hospital. And it was just, you felt the outside world had come in and there was a kind of normalization. Because what happens when you get a diagnosis like cancer, you feel totally isolated. Suddenly, it's as if you've been expelled from the world of the well into the world of the ill.
Mm.
And our hospitals, to a large extent, build that division. You've entered a new space now, and there's nothing familiar anymore of the outside world. But here was the outside world, in a way, coming in through these volunteers and bringing good cheer, spending time with you, listening to you, making you feel as if you were still the person you always were and are. So, and there were support groups, because my first question was, I'd like to meet someone who's been through the kind of cancer and the treatments that you're not now going to give me, because that is the best way in which I felt I could keep my spirits up. They were a symbol of hope, that I could get through these very punishing treatments and there was light at the end of the tunnel. And there were these wonderful support groups where you could just come, you could share your fears, which you can't often do with your own family. You could let your hair down. You shared the fact that you felt awful, that you were fearful, that you felt that you were grieving, and everyone understood where you were coming from. They'd been through it, and they didn't pity you, which is something no one wants. And instead they gave you tips of how they coped, and what to expect and how you should prepare yourself. So it was a wonderful sharing. When I came back to India, I realized it was very difficult here. To begin with, no one wanted to say the word cancer. And then it suddenly struck me, my God, it's still a stigma here. No one wants to reveal this cancer diagnosis, because I came back with the intention of trying to build support services for people with cancer and their families. And I was met with a lot of suspicion by the medical system itself. Doctors said to me, "What are you going to say to my patients? We don't think really you have much to share. What they need is medical advice now, expert advice." And no, no, no. In the West, you see, they have no family. That's why they need these support groups. In India, we have the family. And I had to tell them, but the family is equally distressed, if not more. The family needs support as well. It's not just the patient, it's a disease that affects everyone in this family. And the fact that we don't have as I mentioned to you, I was doing a PhD and I didn't know anything about cancer. I said I had so many misconceptions. People here have misconceptions, and I had brought a lot of pamphlets back from Princess Margaret Hospital, where I had my treatment. Simple pamphlets for patients. What is cancer? What is radiation? What to expect? What is chemotherapy? Simple diet advice, targeted at patients. There was nothing in the hospitals. And when I went to I remember visiting this outpatient department. I was shocked. Everyone's sitting there in stony silence with their heads down, as if this is the end, nothing's going to happen. Now cancer, it's the ultimate. And when I went up to someone and I said, because I had got permission to speak to some of the patients ultimately, and said, "I'm a cancer survivor, I'm okay." And this woman just looked at me and burst out crying. And this her father, who was there, said, "How dare you make her cry? And you're not a cancer survivor. You look normal." So I said, my God, if your relatives think like this, what hope do you have? And I realized how important it was to have support services. Psychosocial support was crucial. To have practical support. A woman who's lost a breast needs to know that there's something like a breast prosthesis, an external breast prosthesis that she can use. Trying to help people feel normal again and feel wanted again and feel part of society again. Such an important area of care and recovery, which unfortunately was being perhaps, I overlooked. And perhaps not, doctors didn't even realize how important it was at that point. So it was hard work in the beginning. It was breaking new ground. But I was motivated, I was persistent. I think my own experience with cancer uh, made it clear to me. I knew the truth is that you need psychosocial support. You need to meet someone with cancer who's now well. You need to believe in your ability to fight the disease and to keep living on in the best possible way. So that's really what's motivated me throughout my journey since then as a support person. But I also learned another lesson, which, of course, you mentioned right at the beginning, that a large number of our patients come with very advanced disease.
Right.
So there comes a time when they're told, I'm sorry, there's not much we can do for you now. And it's generally the family who are told this. This is the other thing. There was very little communication between the doctor and the patient. In fact, the first thing people said to us was, don't tell them they have a cancer diagnosis, the family members. So here were these patients extremely sick coming to a cancer hospital. And the message was very clear to them, don't talk about what you're going through about cancer. Don't mention that word. And so, it was just an abysmal situation. And I realized we had to do something about it, especially when 70% to 80% had advanced disease. And my question was, they're going to be abandoned now.
Mm.
Who's going to look after them, for the rest of their life? And the family was completely lost. Most of them, because we started with the All India Institute of Medical Sciences in Delhi, are people, poor patients. They had spent all their savings, they were in debt, you know, and now what were they going to do? They were just told, take your patient home. So that's how CanSupport started. I felt there was a need for home care, going to the patients in their homes, supporting them, looking after them right till the end. And that's when my own education about palliative care started.
Very interesting. Because I'll tell you, I think
Yeah.
Harmala is, instead of moving away from cancer care, actually moved towards it, took strength out of what your own suffering and, created this organization. You know, but I just wondering, in your initial days, I was reading, going through the CanSupport initial days. Morphine is a basic medicine, I mean, in that sense. But you had a huge problem getting access or getting the license to deliver morphine at a patient's home. So, what was it like? What were you fighting? What was your fight up against? Years of bureaucracy, layers of what permission, documentation. What was that?
I think it was basically ignorance, the fact that our doctors really didn't have experience in using oral morphine, and that they had been educated in the belief that it was addictive and should not be given to patients, because really the people who we received the greatest sort of blowback from were the medical community. No,
Mm.
no, 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 we can't use oral morphine, because if you go to the government, they would have an expert, a medical expert on the board, whose opinion was asked, and this expert was saying, no, 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 we cannot give oral morphine. We'll have so many addicts in this country. It's addictive. It must not, you must not give it to them. And it was just fortuitous that one of the health secretaries finally was someone whose own mother had breast cancer, died in extreme distress and pain. And when we approached him, he understood how important it was to look after people, to give them that comfort, and to take care of that excruciating pain at the end of life. So he said, no, I understand what you're saying. And I told him, at the moment, we have a system which is so complex. By the time you get one license, the other license is expired, because they were all, it was a sort of like you had to get license from here, from there, whatever. And I said, we have to simplify it. And fortunately, the Indian Association of Palliative Care also took this up. And gradually, inroads were made. First of all, they couldn't understand home care. They always asked me, where is your institution? Where your patients are coming in. I said, they're not coming in. We're going to their homes. Oh my God, you're going to their homes. How can we have oral morphine in the community? I said, but we will look after, we will make sure that the oral morphine is used for the purpose for which it is given. And our doctors are trained to use it. And not only that, by this time, the West had produced a great deal of evidence to show how it was really so important to use oral morphine. It was totally safe. It was not addictive. The question of addiction at the end of life just did not arise. So basically, we needed doctors also the medical community to educate itself regarding oral morphine, let alone those who were going to legislate on it, or the bureaucracy. So it required a great deal of advocacy. People now began to use oral morphine slowly. In Kerala was, of course, the trendsetter there. And evidence was coming out to show that it was not at all addictive, and that in the Indian situation, we could use oral morphine without it going astray or being misused. So it did take time. And I mean, I remember almost 3 years before we were finally able to convince the authorities and able to simplify the act, so that we just had to go to the drugs controller to get a license.
Wow, what a journey. And it took you 5 years, right, to get that license?
It took us 5 years. I tell you, it's not over, because despite the fact that we now have a much more simplified policy, and the government of India has laid down rules by which oral morphine is to be made available for palliative care, many states still don't want to give a license. We are struggling at the moment with the state of Haryana, which absolutely refuses. So, I mean, the struggle is not over. It's ongoing.
What an
But some
irony.
headway has been made. Yeah, especially as you say, 4%, huh? Of people who really need this care hardly get it.
Right.
I mean, that seems just unfair.
Yeah.
If not downright cruel.
The irony is of the system, if I may say, put it bluntly, you need some sort of a permission to show compassion. That's the hard part, because what it does to the care team, the angst, people are suffering and you want to help them out, but because of these kind of red tapeism, I would say. But it's good that, I mean, you've come a long way, from where you started. Now your permission, maybe only Haryana, as you say, hasn't
Yes,
accepted
hopefully
this.
that will also, that bastion will also fall. We hope so. One continues. You mustn't give up. You have to continue.
Right. So, Harmala, I'm just wondering, we in the home care industry, we do understand that palliative care mainly happens at home. But I'm just wondering, what would you say that why it still sits at the margins of the healthcare ecosystem?
No, I've had a doctor said to me, change the name. I said, why? He said, it's so negative. I can't tell my patients that they now have to go to palliative care, because for them it'll be the end of the road.
And
They have to accept that. So,
right,
I mean, this is the kind of response. And I said, I don't think that's the way to go about it. What you need is palliative care being integrated in the medical system right from the beginning, so that people are aware of it and we journey with them right from the time of diagnosis onwards, so that you're not seen as someone coming in finally, only when the patient is in the dying stage. So that used to be the how hospice care was seen at one point.
right,
But now we know that palliative care, control of symptoms like pain, psychosocial support, is very important right from the beginning. So it needs that integration. And only when you do that will you be able to fight this belief that is not just among the lay public, but amongst the medical community itself, that somehow when they ask a patient to access home care services or palliative care, they have failed as doctors in some way, and that they are now consigning them to death. They're more or less telling them this is the end. Now you're going to die, and it doesn't have to be that way at all. We need to integrate it. I'm all for making it part of the public health system too, because so that we can get it right to the grassroots level, to where actually our population lives in the villages of India. We have very elderly population living there, and
Right.
they have the need for palliative care. And all of us NGOs, we are limited to some extent, but the government has the capacity to actually step up and provide this care. So we have to move away from this feeling that palliative care is synonymous with death and end of life, and the fact that it's not important. It is important. Death is important. Yes, you try your best. We want to live, but to live with dignity, to
Right.
live with quality. Who doesn't want that? And each one of us one day will need this. That's the irony of it. So you're trying to reject or trying to ignore something that one day you will beg for, you will want. And this is the tragedy here, you know. And so I think we have to work at many levels, this psychological level, the mental level, those blocks that are there. We have to give people proper information, simple information. We have to get people who have benefited from this care speak out. They are witnesses to what is possible. The family members often are. They tell us what a load has been lifted from them, how they can carry on with their lives because their loved ones went in peace and without pain. So I think that there's an awful lot to be done in many areas. But more than that, each one of us has to understand we are not just a physical body. We have a mental side to us, psychosocial side to us, and a spiritual side to us. And that is very important that we nurture all of them. And at the end of life, often, it is the spiritual journey begins. You
Mm.
start questioning the meaning of life, what it means. Why were you here? Now, where are you going to go? We don't have all the answers. But a person must have the right to explore these without feeling that it's wrong, it's depressing, don't talk about it, don't think about it, you know? So that kind of stigma, that the society, we have to work at a society level. Society has to understand that death is a part of living and of life, and we have to face it, and we don't have to face it alone, and that we can face it together as a community, as a family. But everyone needs to support each other, and the love and compassion that you talked about. We need to build those compassionate communities. And so lots of work to be done. And I think that progress is being made. That's a good sign, maybe too slow. But I think once we change this mindset, that's going to be very helpful. As we've seen is slowly happening in the case of cancer too. The people are now talking about the fact that yes, they have cancer.
Right. Profound thing that you said. We all are actually walking each other home, and everyone probably is thinking, or in a delusional thing, that it's not going to happen to me or to my loved ones, but it's going
Exactly.
to eventually catch up. So, apart from there's so many things we need to do in palliative care, but any particular thing that you think should change immediately? Any particular rule uh, that you think should change or make easier for people who are in home care to provide palliative care? Because see, CanSupport is a big organization now,
Yeah.
right? But there are so many
Yeah.
organizations who want to provide home care, palliative care at home. Now they will go back to that your morphine journey. They have to go through that. So you have set a good precedent, but I'm just wondering, is there any rule that needs to change to provide palliative care at home, or it's all set? Anyone who has a home care organization, registered entity, can provide palliative care at home?
No, it's not like that because I think we have to work with other institutions. We have to work with the hospitals from where the patients come. We have to
Mhm.
work with their doctors. When patients come to us, ideally, we would like the doctors who have been treating them to be available to our palliative care team so that because they are often the specialists in this area,
Right.
and and consulting with them is only going to help the patient and the family. Plus it will provide that sense of continuity for the patient. They
True.
won't feel they've been abandoned, but they're part of the continuum of care. Continues, it's going on. I think doctors don't realize that by doing that, they themselves do themselves a great service and favor, because patients don't feel that the doctor has no interest in me, but actually are very grateful for this continuing support that's available. So I think that barrier has to be broken, and I think that the medical system is now, of course, providing programs, education programs. There's a PhD in palliative care. But I think young doctors, very young doctors who are still have that spirit in them of caring, which is why they came into medicine. They're eager. They still have this feeling that, they'd like to be of service. They must be exposed to palliative care.
Mm.
It must become part of the medical curriculum. That's very important. They must be taught about oral morphine, everything right from the beginning. And so and their mentors, it's very important because there's a mentorship in medicine. You look up to your superiors and people. They themselves must have a positive attitude when it comes to palliation. And I see no reason why they shouldn't, because everyone's working for the same goal, to keep the patient as comfortable as possible, to do the best for the patient and the family. What we lose sight of, I feel, is the person. Over time, you become a case, you become a number, you're dealing with so many, you often, you don't realize this is a unique human being, this is a person, just like you. And often what that person needs is just a personal touch. They don't need the latest machine. They don't need the latest medicine. They just need the presence of the doctor, a compassionate presence. Just sitting with them, just explaining to them, maybe just talking to them about their life. Because they're much more than just a patient. You know, it's that human connection. We're losing that human connection. Now, what rule can institute this connection? I don't think it's a rule. I think it's your humanity. We have to learn to feel, because if we feel, actually, we do ourselves the greatest favor. We will feel so happy, so good about what we've done. It doesn't matter, well, that patient, finally we lose that patient. We're not losing a patient. What we are doing is we have gained their love, we have gained their trust, and we have given them something precious, the gift of caring for them. So I think it's a way of looking at what you are doing in a manner that lifts you and doesn't bring you down. Because if you are impatient, if you feel that your workplace is not supportive, etc., it does all kinds of things to you. It's true, you become short tempered, you are unable to keep that time for yourself as well. Everyone needs time for themselves. So, and you can't give to your patients. You can't give to your patient. What do you have to give? You've got nothing to give because you haven't invested in yourself. So it's very important, I think, for young doctors, young nurses, people who enter this profession, health workers, to be taught the very basic rule that you're going there to engage with another life, and it doesn't matter where that person is situated, whether they're in the village, they're in the city, they're wealthy, they're poor, they're precious for who they are, a human being, and that we're all connected, and that your ability to communicate with them, it actually defines you as a good carer. You're a healer. You're not just a doctor who fixes bodies. You heal lives. That should not be ever lost sight of.
Yeah. End of the day, we are healing patients. We're in the business of healing patients.
Oh,
That should be our motto.
so that, and I think home care has to project that in a very strong way.
Yes.
Because you're in the home, you see people in their surroundings, you see the families, you see how they're struggling. The illness may be just one small part of the rest of the struggle that's going on there. And we need to be the people who are able to convey that
Right.
back to the institutions, because institutions, to come to think of it, will never be compassionate. They don't have that capacity. It's the humans there. And so I think we are at the forefront of this care. We are exposed to this. And I think we have this duty in our, on the other hand, to convey this to the rest of the medical system. Because otherwise, just continuing in the same way in home care, that, the same kind of interaction that they received in the hospital is not going to help our patients. So we have to change ourselves first.
Change should start from within.
We have to start from within. It's always from within.
Interesting. Dr. Harmala, we have a segment called Rapid Fire. It's
Yeah.
nothing to do, I mean, it's just a simple chit chat. So I'll be asking you a couple of questions and you reply with your own, like one line or anything of that sort. What is your favorite food, if I may ask?
Something that's not chilly or too oily. So I love vegetables. I never thought I'd say this, but yes, I love sauteed vegetables more than anything.
Okay. Your favorite book so far? Your favorite book?
A favorite book? Well, the number of books is difficult
Yes,
just to
I get it.
say one. You get on one, but I think, the stories of cancer survivors I find very inspiring. And I have a number of books that, talk about these journeys that people have had. It inspires me because it shows me the strength of the human spirit. So anything to do with how people have faced adversity,
Hmm.
really, I find extremely inspiring. And everyone faces adversity.
Favorite place to relax?
Well, now it's Dehradun, where we are now living in Ankara. So I love just being in the home, reading a book, listening to music, watching the sunset or sunrise, looking at the flowers at home.
One thing you cannot live without.
Cannot live without.
Huh? Anything
Meaning,
like any product or device or any routine that you know you have to do it. You do it every day or anything.
well, I do like to have my coffee break during the day. That keeps me going. And it's lovely to, have a chat with a friend or go out and meet someone, have a leisurely lunch. So those are the simple things, small things that I love doing. I often forget to take my cell phone, I must tell
Oh,
you, much to the horror of my friends. who say, we've been calling you, where have you been?
Dr. Harmala, someone who's taking care of a cancer care patient at home, what one word or sentence you would tell him uh, to make him feel good? I mean, maybe he's feeling down or very depressed. What one word of
The
support
carer
that you
or
think?
the
The
patient?
carer, for the
The
carer,
patient,
for the carer,
for the
caregiver.
caregiver of the
Hmm.
patient.
Right.
Yeah. Well, I think we need to tell them they're not alone. We're with you every step of the way. And we're always available. So never hesitate to call us, to reach out to us, and that you are as much part of the team as anyone else here. And we need you. And thank you for the privilege of looking after your loved one.
So, what's a typical day at CanSupport? I mean, how many patients are you serving in a year
Well,
in palliative care?
there are thousands now because we're not just in Delhi and the NCR. We're in Jharkhand, we're in Punjab, we're in Haryana, and of course there's Gurgaon. So we are spreading all over the place. So the patients are now in thousands. I don't know the exact number, and we have many, many teams out in the field now. But still, not enough. There's still need for palliative care, and we keep on getting requests. The only thing that confines us is the fact that it's a free service that we offer, and we need the funds to be able to do it. We must pay our doctors, our nurses, counselors. They're out in the field. They're specialists. They deserve to be looked after as well. They have families.
So, thank you, Dr. Hamula, for turning your survivor story into a service and service into a system that India needs to learn from. And we at Homecare Association of India, I'm really glad and feel honored to have you with us today. And thank you, Dr. Hamla. Wish you all the best, and maybe we will collaborate sometime later. Definitely. Thank you.
Well, thank you for this conversation and giving me an opportunity to share my thoughts